Welcome. I'm excited to give this lecture. I worked pretty late last night, so I apologize if I'm yawning a lot during this. This topic does not bore me. I actually love this topic. I'm just got up early. So because we do have a limited amount of time to talk about the pediatric airway, I'm going to focus a little more on intubation. However, there's a lot of good information in here for anyone who's managing a child whose airway may need some assistance. But we don't have time to talk about everything. So I've not included like vent settings or medication choices, but I'm happy to answer those questions if they arise. Next slide, please. So airway emergencies in children can come about for several different problems. It could be something as like a severe lung problem like asthma or a pneumonia. Maybe your brain's not sending signals to breathe, like an injury or an ingestion, or of course it could be the airway itself if you've got swelling from croup or from an inhalational injury. So those of you that work in emergency departments will see all of those injuries also in adults and already know how to take care of them. But kids can make us especially nervous, and especially if you have to secure that patient's airway. My goal here is to help you know how to modify some of the techniques you already know specifically for children. Next slide, please. So we're going to start with some of the anatomic changes to know what to expect. Next slide. First, not shockingly, the pediatric airway is smaller than the adult. But if you think about it, it's not just smaller in diameter, it's also shorter, which means that it's easier to accidentally extubate a child. It's also easier to accidentally right mainstem a child. Newborns especially, their trachea is so short that endotracheal tube can be in a perfect position, and if they simply turn their head to the side, they completely come out. So the other problem with having less space is you also have less space in the mouth itself to see everything that you need to in order to place an endotracheal tube if you must. Next slide. Children also have a lot of cartilage. This means that their airway is going to be more elastic and more flexible. In some cases, their airway is so flexible that it can completely collapse when they breathe in or out. This is a problem called tracheomalacia or bronchomalacia. But on the other hand, this kind of works to our advantage when it comes to positive pressure ventilation, when it comes to bag valve mask ventilation, is that children respond so well to it for a variety of different problems. It's also why the most important skill that anyone can learn that has to care for a child who's having an airway emergency is bag valve mask ventilation. With that skill alone, you can save that child's life. Endotracheal intubation is cool, but bag valve mask ventilation, it will save lives. Next slide. Kids also have larger tonsils and a relatively larger tongue that can all just kind of get in the way, giving you even less space than you normally would have. And next slide. Lastly, the airway actually changes as you age. It's part of the reason I like these two pictures that I found on Google that shows that in the infant, kind of on your right, that your larynx can be as high as like C2 or C3, whereas as you get older, that larynx lowers to C3 or 4 at 7 and as low as C4 or C5 in adults, which means, next slide, that angle that you have to go around is a little bit sharper the younger you are. So we'll talk a little bit later when it comes to difficult airways, because the angle is sharper in younger children, anyone under the age of 1 is considered a difficult airway. So tools that you can use to address some of these anatomic changes. Next slide is first positioning. Oh, sorry, back one. First positioning. The picture that says tool 1 positioning shows the optimal position for a child's airway. Now, I don't know how many of you took basic life support back, I think it was 10 years ago, where they would talk about positioning as one of the first things to help someone when they were having trouble breathing. We still use this, it's just not necessarily the first thing for basic life support. But this is the appropriate position. If you turn this slide on its side, this kid would look like they're sniffing. And the way you can tell that you're in the right position is that there are three things to look at. One is the glabella, or the plate right between your eyes and your chin are going to be horizontal. The second one is that your neck is going to be wide open rather than closed. And third is that the external auditory meatus, the front part of your earlobe, is going to line up right with your just about your sternum. And to get to this position, we'll often use like the shoulder roll. And in this case, we also show a headrest, but kids also have a big noggin. So sometimes a headrest is going to be a little bit more shallow, or you may get away with just a shoulder roll to get to the right position. Next slide. The second tool is the right size of equipment. Now, here I have listed endotracheal tubes, and we're talking about face masks, bag valve masks, laryngeal mask airways. Having the right size for the patient is going to be very important. You can use, charts like this or equations like I have listed, but during an emergency, math's not fun on a normal day for most people. During an emergency, it makes it even more stressful. So I recommend using something along the lines of a length-based tape, or I've got an app on my phone. There are a number of different ways that you can pull something up to get the right equipment sizes that you need quickly. But it's also good for general emergency departments to have the variety of equipment they need for children of all sizes. Next slide. It also helps to choose the right equipment for the job. And here I'm going to focus on the laryngoscope blade, because I want to remind you that they're used slightly differently. The curved blade is designed to sit within the vallecula, that space between your epiglottis and your tongue. And it actually uses some of your ligaments in there to lift everything out of the way. You've got a ligament that runs between the hyoid bone and your epiglottis, the hyoepiglottic ligament, that you basically use to lift everything out of the way. Remember how we talked about kids being very floppy? That means their ligaments can be very stretchy. Well, a straight blade is designed to sit over the epiglottis and just manually lift everything out of the way. The reason I bring that up is that if you're struggling with a curved blade, you might have a little more luck with a straight blade, especially in young infants. Some of us pull a straight blade out, and anyone under the age of 2 first. It doesn't mean you did it wrong if you get it with a curved blade. Just if you're struggling, it's nice to have a backup option. Next slide. Speaking of backups, the last tool is having more than one plan. A lot of us, if we're managing an airway, we think about RSI, but what are you going to do if that doesn't work? It's always nice to have, a lot of times we'll think to move to bag valve mask ventilation if this doesn't work, or we'll think, depending on the problem, maybe go with a smaller endotracheal tube, or maybe dropping a laryngeal mask airway. But having a backup plan and the equipment immediately available is very helpful. Now, I'm actually going to go back just a little bit. Next slide. Back to tool 3, choosing the right equipment for the job, because while we're talking about intubation, I want to stress that we use the most least invasive method necessary to care for the child. So any child that can make noise while they're coughing, or if they're able to speak or cry, they let you know they're getting air in and out. If they're awake enough to be afraid of you, that means you're getting enough oxygen to their brain. So depending on the disease that's causing their emergency, you might be able to get along with a simple nasal cannula, non-rebreather treatment, or a high flow nasal cannula, which is shown here. So even in situations where you have a child with severe asthma, severe bronchiolitis, or even severe DKA, a lot of times we will do our best to get away without intubating the patient. All right, next slide.
Could I ask anybody who's not muted to please mute their telephone?
That's me.
line?
That's my dog. I'm sorry.
That's your dog. Okay, just checking.
I'm so sorry. If you need, I can go and like grab him and put him on my lap. But he's barking at the garbage truck. It'll go away soon.
No problem. My dogs were just barking at the same time, so I wanted to make sure it wasn't me. I apologize. And
no, you're just fine. I was just thinking, I'm like, why is my dog still barking? Moving on to physiology. So next slide. Right here. The first. Next slide. First is that children have smaller lungs and they have a higher metabolism. So they're going to develop hypoxia when apneic faster than an adult. If you think of oxygen like gasoline, kids have a smaller tank than adults. And so kids are going to be kind of like a gas guzzler with a small tank. They're just going to run out of gas a whole lot faster. They're going to run out of oxygen a lot faster than adults without a steady supply. Next slide. To illustrate this, a lot of you have already have seen this graph. This is a rather famous / infamous graph, illustrating how fast children can become hypoxic when they go apneic. And it shows that a normal 10-kilogram child drops their oxygen saturation about as fast as an obese 130-kilo adult, whereas a normal 70-kilo adult can go for quite a bit longer. So you're just going to have less time if the child falls apneic before they drop their oxygen saturations if you have to intubate them or intervene. Next slide. The other point I want to make is that crying increases the amount of flow across your airway 32-fold. So if the child has any narrowing of their airway, such as croup or from a foreign object, they're going to have that much more trouble breathing because they're trying to move so much more air across a small narrowing. This has actually led to a saying that if a child has trouble breathing, you should, next slide, leave the kid alone. Now, I mean, if you have to intervene, you should intervene. But there's a particular situation we're going to talk about a little bit later where this is going to come up, and I'll say this is a kid that you actually want to leave alone. But if you must intervene, you should. But if you can get the kid to calm down, a lot of times it'll give you a better idea for what their true respiratory status is. So our tool for this, thanks, Catherine. Our tool for this is oxygen. There are many ways to deliver oxygen, each with their own benefits and uses. And the most common method we use is the nasal cannula, which is really good for long-term oxygen delivery and uses lower flows. But I want to make a huge point here. If you look at the nasal cannula, that second line, and it says the oxygen flow is usually like half a liter to 4 liters per minute. Even with 4 liters per minute, you're only delivering about 40% oxygen because when they breathe in, they're still getting a lot of room air. If you go 2 more lines down, you see simple face mask, which in order to be effective is used between 6 and 10 liters. And with a simple face mask, your oxygen delivery at 10 liters is about 40%. So while yes, you've gone from 4 liters to 10 liters on the tank, if you went from a nasal cannula to a simple face mask, it's actually a lateral move, even though you're trying to deliver so much more oxygen, they're not actually getting that much more oxygen, which is why if you're maxed out on a nasal cannula or a simple face mask, the better move is to go to a non-rebreather face mask, that second to last line, which you basically crank up all the way, but you can get up to 95% oxygen delivery because they're breathing out of a reservoir. So that's usually the simple face mask, which has a bag attached to it. Next slide. So oxygen can also be used for pre-oxygenation. Going back to the gas tank analogy, our air is only 21% oxygen. So if you can get the air in their lungs up to 40% oxygen, even with a nasal cannula, you've effectively doubled the size of your gas tank. That's going to give you twice as long before that kid's going to drop their oxygen saturations if they fall apneic. Same thing if they are apneic, you can use oxygen for apneic oxygenation. So if you're doing a procedural sedation, or if you're intubating a patient, it's going to give you that much longer before a patient's going to develop hypoxia, time that is going to make you less stressed seeing that their oxygen saturation is doing okay. There was a brilliant study that looked at pediatric surgeries where learners were intubating children and measured how long they had before they developed mild hypoxia with and without 10 liters of apneic oxygenation. Next slide. The results were impressive. They found that 10 liters of apneic oxygenation resulted in 80% fewer desaturation events and more than doubled the time a learner had to intubate a patient with healthy lungs. So throwing a nasal cannula on the patient, even if they're not breathing very well, it's a tool you can use in order to prolong the amount of time you have to care for that patient. The challenge, if you do that underneath a bag valve mask, is that you may struggle with the seal. If you're struggling with the seal, you may have to get rid of it. But if you can get a good seal with it, it is definitely worth trying. All right, I do want to talk briefly about the difficult pediatric airway, because I'm kind of describing lots of normal, what we typically see, how a child's going to normally differentiate from an adult. But there are a few things I want you to think about before that this kid might be especially challenging. Now, first, next slide, is the good news, is that pediatric airways are very consistent. In fact, they're more consistent than adults. If you were intubated 6-month-olds all day long, you are going to find less variation between patients than you would in adults. The problem is that when you're intubating, or if you're managing adults' airways, and then you take care of a 6-month-old, you may find that corner is going to be a little too sharp. You may find you have less time to intubate that patient. Your usual technique may not work quite as well, just because it is so different from the adult airway. Next slide. So because of that, part of the reason, because that angle is so sharp, one of the things you should think about is all kids under the age of 1 is going to be a difficult airway. You're just going to have very little space. You're going to have very little time to manage to intubate that patient if you must. Other things that clue you into a difficult airway is anyone who's ever had facial surgery, just because sometimes visualization will be a lot different. Anyone who's had heart surgery, that's a little more for physiology, because some children require that negative pressure breathing in order to generate their cardiac output. So if you take that away and try to turn it to positive pressure, they could code. Any child with an upper airway tract obstruction, whether that's foreign body, abscess, viral infection, is going to have a difficult airway. Part of the reason why we don't tend to sedate patients who have like a peritonsillar abscess. And anyone who's had a history of difficult intubation, all of those will have difficult airways. Of course, it also depends on the disease process. This is very similar for adults, right? If you have an airway burn, you're going to have a lot of secretions or debris. It's going to be hard to see. If you have anaphylaxis, it's going to have almost more of an asthma picture, and you're going to have more of an obstructive process. Croup, you're going to need to go with a couple sizes too smaller in order to intubate that patient. Epiglottitis, it's going to be virtually impossible to see that airway, and you may not even want to touch it if you can avoid it. Trauma, hard to see or place the tube, see from bleeding. Treacher Collins, those patients have some facial deformities that can make it challenging to see their airway. So if you see one of these disease process, just like you would in adults, that airway is going to be difficult. All right, I want to pause briefly for questions before I move on to the next thing. Are there any questions? I haven't seen any in the chat. Hopefully I'm not moving too fast.
Dave, if I can make a couple of comments, if there are any questions, anything in there?
There's no questions in the chat.
Okay. So maybe it's just because I'm older. I say any kid 2 years or younger is a difficult airway by definition, instead of 1 year. You were kind of talking about how hard it is to do math in the middle of a code and remember the tube size. One of the things that I always remember is most of my patients have hands, and their pinky is about the size of the tube that you want. So you just hold the tube next to their pinky, it's going to work, okay? For those of us who practice for a long time before the back to sleep idea, kids used to have whoppingly big occipits, and it would really crimp their neck significantly when you tried to get them into sniffing position. Now that more kids are doing back to sleep, they tend to have a flatter occiput, so you don't have to do quite as much of a shoulder roll as I think I trained to do originally. And then you brought up heart kids, and just, you know, one thing that I remind everybody is, you know, for some reason we all were trained that, oh my God, it's a congenital heart, don't put too much oxygen on them. Well, yeah, except if we're in a situation where we don't know what's wrong with the patient, but we do know that they have a respiratory problem, you put on the oxygen appropriate to your patient, okay?
There is a question that's just popped up. Are kids with Treacher Collins more likely to have airway issues than need intubation by nature of their condition?
And the answer to that's no, actually, based on all the information that I have read, even though they typically have several facial deformities, they don't necessarily have any more airway issues than others, to my knowledge. Now, an ear, nose, throat specialist, if someone out there is a specialist in ENT, you're going to know better than I am. I don't care for many of those patients. If they do have significant airway abnormalities, or facial abnormalities, sometimes those kids will come in with a trach and they'll already have an airway, but I don't expect them to develop airway abnormalities more frequently than someone else, or sorry, more like airway.
Which led so perfectly to one of my other comments was going to be, one group of kids that we do see frequently are Down syndrome patients. Remember, Down syndrome patients have flat maxillas. They tend to have midline defects, and their airways also, even into adulthood, can be more challenging and more anterior. And then I think you're going to talk a little bit about equipment, Dave.
I already did my very
Okay.
brief equipment spiel.
So just people, if you're using video laryngoscopy, CMAX or anything like that, you get beautiful views, but it's really deceptive how anterior the pediatric vocal cords are. So you might see them great in your screen, but getting your tube to go that anteriorly is really challenging. And almost, the old kind of straight tube with a little bit of a bend at the distal portion, I almost sometimes go as far as doing almost a C-shape or U-shaped ET tube to make sure that I go super anterior if I'm using video laryngoscopy. If I use direct laryngoscopy, it's more, you can actually see where you're going a little bit easier, and it's not as deceptive. That's a trick that I found with the screens.
No, you're absolutely correct. When you use direct laryngoscopy, you straighten things out a little bit better, and the slight curve's all you need. Whereas if you have video laryngoscopy, especially with the glide scope, the glide scope is so curved that you have to bend that tube almost into a U shape in order to follow that line to get around that corner. Thank you, Jeff. Those are very good, helpful pointers. All right, I want to take a minute as well and talk about one of the most frightening problems we face in emergency medicine, I feel, is the airway foreign body in children, because this is something that'll take a child from being perfectly happy and healthy to killing them very quickly. Airway foreign bodies are most common in kids under the age of 3, because if any of you have kids under the age of 3, when you see them when you take care of them, they love to explore their world by putting things in their mouth. So they're constantly putting things in their mouth. So they pick something up, it goes in their mouth. The mortality rate for a complete airway tract obstruction is 50%. This is something that is sadly very problematic. Most common foods: hot dogs, candy, meat, grapes. So if I'm ever at a event where there are hot dogs, I always worry just a little bit. And this is why we recommend that parents cut up hot dogs into very small pieces, grapes, even cut those up before giving them to small children. There are 2 things you need to think about when someone comes with an airway obstruction: is whether or not this is partial, whether or not this is complete. Now, partial airway tract obstructions, they are able to cough, talk, they're still able to make some noise. If depending on where it is, if it's in their trachea, it can still be very problematic. They need a lot of distress, but they may still have some coughing or crying. If it's lower in their airway, they actually may be misdiagnosed with asthma. You may have wheezing on one side, and those patients, you basically, they still have one lung that works, so we can send them to the operating room to have them take it out. These are the patients who we talked about leave the child alone. If you have a patient who's got a partial airway tract obstruction, those are the ones you want to leave alone. That if you make them upset, they could actually change that partial obstruction into a complete obstruction. And kids with a complete airway tract obstruction are unable to cough. They're unable to talk. They're unable to make any noise. They are scarily silent. They're going to rapidly fall unconscious, develop hypoxia. Their heart rate's going to slow, and they're going to die unless you're able to get that obstruction removed. If you have a child with a complete airway foreign body, but really the first thing you can do is performing relief maneuvers. And this is something that anyone can do. And relief maneuvers are things such as whether it's chest compressions if the patient's unconscious, or whether it's something along the lines of the Heimlich maneuver. I think we call them abdominal thrusts now, in order to try to expel the foreign object. Because if you can get it out before the patient becomes unconscious, they're probably going to do well. If not, and they fall unconscious, at that time, if you haven't already alerted emergency medical services, you definitely should. And if you are with emergency medical services, you can actually just take a quick look. I recommend direct laryngoscopy in this case, because the McGills fit so nicely up along a direct laryngoscope. The video laryngoscope doesn't have that nice little notch, which is why a direct laryngoscope may work a little bit better. The cases that I have read about when you're taking a look and someone has an airway foreign object is that the airway itself is not visible. There's a lot of swelling, there's edema, and most of the time they can't see the foreign object or pull it out. If you can, that would be fantastic. But if you don't be surprised. Next slide. The next step is to try bag valve mask ventilation, which is a little counterintuitive. A lot of people, you think, well, if they have an airway foreign object, I'm just pushing it in deeper. Remember how their airways are flexible? You might be able to expand their airway enough to get air around on one side, especially if it's an abnormally shaped object. If it's something perfectly round, you may have a little less luck and end up pushing it deeper and be stuck. But this may be enough to temporize them to get them to the operating room if you're able to bring their oxygen saturation up enough or get them out of such severe distress. Next slide. Oh, sorry, back one. If that doesn't work effectively, you should attempt intubation and try to advance the object as deeply as possible. You're effectively sacrificing one lung to get a good lung. This is truly a temporizing measure. And you push the endotracheal tube as deep as you can, and then you withdraw it to a normal position and see if you are able to get oxygenation and ventilation, and then you can take them to the operating room. Lastly, you can do a needle crike. If none of that is working, the patient's still hypoxic, you're still unable to get anything else. This is very unfortunate when you get to this step, because if that doesn't work, there's not a whole lot more that we can do other than continue just trying to remove it. All right, cases. Another good stopping point for questions or comments. Tools for removing a foreign object. I've seen advertisements for them. I haven't seen any studies on them, which a lot of these patients, when you look at airway foreign objects, we're getting our data is from case reports, because there's not going to be a randomized controlled trial on what's going to work and what's not going to work. So if you have an object that claims it can remove a foreign object, you're welcome to try it. That's not something that's made its way into the literature yet, as far as I'm aware, but that's a good question.
And just to reiterate one of the things that you were saying before, Dave, it's like we get lots of patients who present with choking, gagging, and parents put their finger down their throat and say, I felt a hard thing. I know they swallowed something. Well, you know, a lot of times that hard thing that they're feeling is the vallecula or the epiglottis or the roof of the kid's mouth.
Right.
So So long as a kid is making noise, like all parents know, a noisy house is a safe house. When things get too quiet, that's when you got to worry about your patient and worry about your kids at home.
Yeah, and there's more than one too. So you'll get a lot of kids who get a partial airway tract obstruction because they've got a coin in their esophagus. Those kids are drooling, they might be retching, and they may look like they're in a bit of distress. You do have, and those kids are ones that you know, shoot the x-ray and you leave the kid alone trying to find out exactly where that object is. All right, let's move on to some cases. You're welcome if you have other questions to put them into the chat. So the first case, speaking of airway foreign objects, is an 18-month-old that's choking. This was around 10 o'clock at night. EMS is called to the scene where you find, next slide, a kid who is in extremis. He's in severe respiratory distress. He is not making any noise. And he has visible effort trying to breathe, but not having any air movement. So those of you in EMS, what would you do in this case? I mean, you know, this terrifies the pediatric emergency medicine physicians. And if this is your patient, so I want you to think, you don't have to answer, but I want you to at least think about it. We already kind of went through this. The first step is to try some relief maneuvers, which they attempted. They're unable to. Micah, that is pretty consistent, that if the coin it looks flat and you see a circle when you're looking at the AP x-ray, it's virtually always in the esophagus. I have not yet seen one of those in the airway. Next slide. So relief maneuvers were unsuccessful. The patient falls unconscious and their oxygen saturation is 60%. They happen to be literally around the corner from our hospital. So fortunately for them, they decided, you know, they've got more resources there. They've got a few other things. We're super close. So they scooped and ran. They were able to get a face mask on. Like that's all the time. It literally was that fast that as soon as they got to the truck, they put a face mask on and they were at our door right away. So they chose to transport the patient. But as the hospital then, if those of you that are in the hospital, what are you going to do to prepare for this patient when you get a message? We had like 2-minute warning, which was we used the time to get all of our equipment ready. And I want you to think for a brief minute, what are you going to prepare? So we prepared lots of different equipment, specifically direct laryngoscope. We prepared McGill's. We had our endotracheal tubes. We actually were very prepared when this particular patient arrived because I had a lot of resources. I think we're 2 slides next. Sorry, the next slide should be transported patient. And the one after that is kind of the equipment that we had. We had our needle crite kit out. We had our intubation medications. Now I had 2 attendings that were on with me. I happened to be the fellow at the time. I had another fellow that was on with me that was sitting in the corner with an IO, like ready to go. I even had a senior emergency medicine resident, so someone who was just about to graduate, out and we go work in the general emergency department. And since the patient was small and the bed was big, he had all of the airway equipment like lined out beautifully. So we had lots of equipment out and ready for this patient when they arrived. So this particular patient arrived. My fellow with an IO was disappointed because my amazing nurse had an IV within 3 seconds. Like the patient was still on the gurney and she had an IV in this kid. We were able to give some atropine and we started to bag him. We gave atropine, basically preparing for intubation on this patient. Bagging him, we were able to get his sats to about 90%. He was still in extremis. Come to find out, the family said he choked. It was on a sunflower seed. So the object may have been atypically shaped enough in order to get air in and out. He intermittently fought us. We got his sats up enough that he would kind of wake just a little bit and begin to fight us. So we prepped his neck just in case we were going to need to go through the neck, and we put him in, got him into the right position. We chose to give etomidate and rocuronium, which, depending on the text, so there's some argument that we should use ketamine instead. Again, there's no clinical trials on this, so this was something where, because we were having some success with back valve mass ventilation, we decided to go with etomidate and rocuronium. Direct laryngoscopy showed just tissue swelling. You couldn't really see the airway. I could see his esophagus though, and I knew his airway was supposed to be anterior to that. I even had a hard time seeing his epiglottis. It's almost like his epiglottis was kind of like folded over. And so what we did is we took the tube and we inserted it as deeply as I could. And I was very surprised that there was no resistance. It felt like a typical intubation. And then I pulled it back out to the appropriate position. And we were very fortunate in that he had complete lung sounds down the left side. He had lung sounds actually even in the right lower lobe, and just had, we had put it in the right upper lobe was where it was at. His pH was 6.97, his CO2 was 90. We ended up putting him on a Versed drip because now that he was getting the oxygen that he needed, he was going to wake back up. And he was breathing over the vent, blowing off all that excess CO2 before he went to the OR. He did very well. We've seen him a couple of times for colds. I actually saw him once and I didn't recognize him. His mom had to stop me and was like, "You don't remember him, do you?" And because he was a happy 3-year-old running around and screaming and making a mess.
Hey, Dave, can you say something about, the way you described this kid? He was completely out by the time you got him.
He was.
Do you need rock and etomidate in that situation, or can you just look?
So that's a good question. Part of it was, while I described him as completely out, he was still fighting every once in a while. Like as we bagged him, he would still move around and try to push us away briefly, and it would break the seal enough that his stats would drop enough and he'd go back unconscious. So because we knew that there was still some awareness there, we felt it was kinder to provide at least some sedation. The rocuronium, again, debatable. In the moment, I think we were concerned about getting a laryngospasm if we tried to intubate this patient without having some paralytic on board. I was going to make the argument you could go with succinylcholine instead because it's shorter acting than rocuronium, and that way, if you do need them to keep breathing, you can get back to that fairly quickly.
Yeah, I think the fact that you were able to have some success with bag valve mask in oxygenating him really gives you the time to be thoughtful in terms of how you're going to approach the kid. And so again, playing back to, it's all about bagging the kids, making sure that you have that time. And if you can bag them, then you can kind of have the more theoretical decision making. But yeah, if this kid is reaching out for you, yeah, I think you gotta consider RSI drugs.
Yeah, but I mean, he was making no noise. He clearly had chest wall movement, but didn't have any air movement. So he was still in that stage where he had, because EMS transported this kid so fast, we were still in that stage where he wasn't completely out, but he was out enough anyway. And I can see that Susan Romero put in the chat here that had to do the Heimlich maneuver on your 3-year-old, which has, was a lifesaver to have that training. Absolutely. It's something that, I still worry about it sometimes when my own kids are eating. Every once in a while when they kind of stop and I kind of look over, I'm like, are they still making noise? Are they still making noise? And then I hear them cough. Okay, they're fine. So I don't think they made a tool called a lifesaver. I've not heard of that one other than the candy, which, supposedly trying to keep kids from choking because it has a hole in the center of it. Anyway, questions about this case? So 50% mortality rate. This was, there's a 50% chance this kid would not have had the good outcome that they did. All right, let's move on to the next slide. Next case is a 7-month-old ejected from a car. So this kid was, next slide, was ejected from a car that was traveling at 75 miles an hour. This was on one of our New Mexico large freeways between major cities. The patient was intermittently crying on scene, but had an obvious significant head injury. Heart rate was 230 beats per minute. Blood pressure was 50 over palp, satting 60% on room air. And the poor EMS crew was looking at this kid, realizing this kid is going to die unless we get this kid moved fairly quickly, packaged quickly, get some fluids on board. And they knew it was a 45-minute transport time to the trauma center, or they could travel 35 minutes the other direction and go to a smaller clinic. And they decided to head towards the trauma center. They were able to get an IV in this kid. Kudos to this crew. Oh my gosh, they've got an IV in this kid somehow, and ended up giving him, I think, 700 milliliters of fluid en route. They put this kid on a face mask. The kid was awake enough, like intermittently so, that was crying, making noise, was still breathing. And once they got a face mask on him, the SAT slowly came up to about 93%. So they had time. So rather than like doing bag valve mask, they left the face mask on and were working to get the IV and to get the kid transported. Now, I described the scene as one patient, right? I'm sure that anyone out there who works in EMS knows that the scene was much more chaotic than that. I'm sure that there was a driver that they had to take care of as well. They may have had to call a second crew, which sometimes in our more rural locations you don't have. So my heart goes out to this EMS team for the amazing work they did for this patient. I mentioned they gave us 700 milliliters of fluid, which is quite a bit for a child this size, but this kid needed it. This kid was persistently tachycardic and hypotensive. They alerted the hospital, so we were able to get this patient ready, get ready for this patient as a level 1 trauma. So whenever we get a patient like this, we get enough of these that we have a team that comes together. We have all the equipment we need in one room. We're very, very blessed to have most of what we need to care for a patient like this. On arrival, this patient was, best way I can describe it, was ashen. Her skin was gray. She was mottled. She had this flattened area on the front of her head, along with this abrasion along the entire left side of her face. Her pupils were sluggish, and her left pupil was a lot larger and like hardly reactive at all. And there are no obvious deformities to her extremities. When you took a listen to her heart and lungs, there were some diminished breath sounds on the left, and her consciousness was very much in and out. Like she would wake, cry, and then she'd fall asleep. And she'd wake up and she'd cry and she'd fall asleep. And I'm sure, Jeff, you recognize that when I describe this is something we see when kids have a pretty significant head injury. Her oxygen saturation, as soon as we got her hooked up to our monitor, just by taking her off the face mask for a brief period of time, was now 82%. So we, put her on some more oxygen. Her heart rate was still 200 beats per minute, with 700 milliliters of fluid in a kid who weighed, I think it was 8 kilos. So this kid already had the equivalent of more than 3 boluses, and her blood pressure was 62 over 38. So we actually started bag valve mask on this patient, brought her SATs up to about 95%. And this patient was continuing to fight us intermittently and was really hard to bag. We couldn't tell if it was because she was fighting us. Maybe we weren't just getting a good seal. We decided to perform RSI. We gave etomidate and rocuronium. And as soon as we gave those meds, the SAT went from 93% to 30%. It was almost instantaneous. So, all of a sudden you go from trying to intubate this patient, trying to make sure you've got the oxygen to get the time that you need, and your time's gone. So I took one look, the tube was too big. We decided to back out and try and bag this patient back up. And we bagged for a whole minute, and the sats just slowly crept from 40s to 50s to 60s, just slowly over time. We finally got back up to the mid 80s where they stopped and hovered. And I was like, why is this kid dropping their sats so much? Thought maybe, you know, massive hemothorax, maybe a kid had a massive contusion, something. So we decided to try one more time. Sats again plummeted. This kid's heart rate started to drop because their sats dropped. We were able to get, using a bougie, the tube in place. This kid was 7 months old, so getting around that corner was hard. The kid was still super hypotensive after being intubated. After intubation, we still kind of struggled to get the sats back up, but the kid was no longer bradycardic. And we started some uncross-matched blood, and the patient began to seize after intubation. So now we were starting her on a midazolam drip, and the chest x-ray showed a massive pneumothorax. And as soon as we put a chest tube in and drained everything out, it was no longer hard to bag, didn't need high pressures on the vent. The patient's sats jumped all the way to 100% very quickly. We were able to wean her down, her FiO2 from 100% down to like 40. And this patient's injuries actually had a lot of significant injuries, and I could read through them as far as like a right temporal bone fracture, left frontal bone fracture, shock bowel from all the fluids we gave. The biggest thing was actually this kid had a right ICA stroke, didn't have any significant hemorrhage. This was actually neurogenic shock. Here I had been thinking I was treating hypovolemic shock the entire time, and instead it was a neurogenic shock that this patient had, and instead epinephrine would have been more helpful for this patient. But we didn't know that until after we had our scans done and could see that this patient wasn't losing a lot of blood other places. And this patient actually did very well, surprisingly well over the course of her stay. Next slide. She was extubated on day 3 of her 42 hospital stay. Most of her fractures were healed at discharge. She had no residual weakness, no difficulty swallowing. She had no observed blindness, although it's lost to follow-up for her vision checks. Still had a hemotympanum, so did have some hearing loss on one side, but expected that as that would resolve, that she may be able to hear again on that side. So this patient actually ended up retaining most of her cognitive abilities and was discharged from the hospital after some time. So the discussion that I wanted to bring up about this case, and this is something that is, I think, fascinating, because we used to jump into intubate as quickly as you can on some of these patients. And it's that decision to resuscitate versus intubate, or where do I put intubation in the resuscitation? Because if you have someone with hypovolemic shock and you use RSI, you may take away enough of their endogenous epinephrine that they may just code on you. Whereas if you get some blood into their system, you might be able to prevent that and have a better outcome at intubating the patient. This particular patient, had we recognized this big pneumothorax first and put a chest tube in, would that have changed this from a high stress situation where the patient is becoming bradycardic to a situation where I could have my intern intubate this patient? And that's right now, I don't think there's a good solid answer for that, but I thought that was an interesting thing to bring up. So child head injury, GCS 3 to 6. I don't know, like, this kid was in and out. I wouldn't say this kid had a GCS of 3 to 6. So I think what EMS did was very appropriate for this kid. Was they kept the sats up, but were able to transport the patient, get enough fluids to bring things up. But let's say in a case where the kid did have a GCS of 3 to 6, breathing around 9 to 10, sat of 90%, I would say in that particular patient, if they're not fighting you and you feel like they need bagging, like if this particular patient, if we started bagging, that bag valve mask would be the way to go, or a laryngeal mask airway in the field. But you're right, if the SAT's greater than 90%, if you're able to throw an end tidal on them and their end tidal's okay, then you could focus on your IV on some of the other cares while you are continually monitoring how their respiratory status is doing. So I know that the saying is like GCS is less than or is 8, you intubate. A lot of times our EMS crews, I have found, especially since endotracheal intubation has been removed from the general scope of practice without it here in New Mexico, without having additional training, our EMS crews have done just outstanding bag valve mask ventilation. Anyway,
Dave,
questions
with that case, I think those of us who trained in pediatrics, we were always taught that it's, kids die from respiratory disease and respiratory arrests. And so when you have a trauma patient, it's still really difficult for us to move beyond the A of airway and feel like we have a secure airway, even when, like in this kid's situation, you're right. Perhaps if we had taken a little more time at that initial presentation, went, oh, even with bagging, I've got no sounds on the right side. Maybe I should just put a needle in. Maybe you could have improved the kid's ventilation without intubation, or maybe even save the intubation, though. Yeah, certainly done the intubation in a slightly more controlled fashion, but it's really hard. I mean, for me personally, if I have a sick kid, I still want my tube, I want to know I have their airway controlled, and it's really hard to back off that way. And, would an LMA have been adequate until we had done more, something like that? I'm not sure what the answer is there.
I honestly don't know. So Micah put in the comments here, is it common for an ALS ambulance to have tiny LMAs? Is anyone here on with Albuquerque ambulance or with an EMS crew? Do you tend to have some small LMAs? Because they can get really tiny. We have them. I don't think I had to use one for a newborn, but they can go all the way down.
Dr. Jolley, did you see the question from Robbie as well? In a child with a head injury and a GCS of 3 to 6, but still.
Yeah, that's what I was trying to answer, saying if your GCS is, the saying is GCS of 8, you intubate.
Right.
But with EMS, I think that you're absolutely correct. If the kid is breathing on their own, if their SATs are greater than 90, if you throw an end-tidal CO2 on them and you're able to monitor them really closely, if they're maintaining their airway and they are maintaining their respiratory status, that you can move to focus on other things. Anyway, so I think that's a great question.
Thank you.
I just want to follow up on the question with regard to the ALS ambulances and the tiny LMAs. So currently there's a national initiative for EMS services to really start thinking about being pediatric prepared. And there is available online, and I wish I could switch to my internet to get you this link for EMS services to get a checklist of all the needed equipment to be pediatric prepared, and the different LMA sizes are on that checklist. So there were a couple of people on the call that are EMS, and I'm not sure if they would be willing to either answer in the chat box or go off mute and answer that question. It's all going to be, in my experience with talking with these services, the frequency of these pediatric calls is so few and far between that sometimes they don't think to be prepared in this manner. So that's why we're really trying to push that. And if you would like more information on how your EMS providers in your area can receive this information, I'm happy to send that out to you. And I will put that checklist in the next tips and tricks going out for the next round of ECHO course information. Okay.
Thank you. Other questions or comments about these cases, or about any cases that you've had? And while you're thinking about that, my heart goes out to any of you that are being affected by the fires right now in Mexico.